Hi, everyone. Thanks for joining today's webinar. My name is Mike Curlin, and I'm a member of the Collaborative for Telehealth and Aging. And in this session, we're going to start with a presentation on implementing age-inclusive telehealth practices for older adults, followed by an informative panel discussion. We're joined by Dr. Laurie Archbald-Pannone and Anthony Nappi from the UVA School of Medicine. They're going to do the presentation and then be joined by Dr. Kristin Ritchie from Mass General Hospital and Harvard Medical School, and Dr. Kristin Rising from Thomas Jefferson University for our panel discussion. The panel discussions can be moderated by Becky Harless from Greenbrier Valley Medical Center. And I'd like to now pass the baton over to our presenters, Laurie and Anthony. Both of you guys, please just take a quick moment to introduce yourselves.
Great. Thanks so much, Mike. I'm Laurie Archbald-Pannone. I am a geriatric physician at the University of Virginia, involved in long-term care, outpatient medicine, as well as a member of the Collaborative for Telehealth and Aging.
And I'm Anthony Nappi. I am a physical therapist and registered nurse, former frontline clinician, and now a nurse liaison for the Virginia IMPACT project from University of Virginia School of Medicine.
Great, thank you. And so that's what we're going to be talking about today is the Virginia IMPACT project that Anthony and I are both a part of. We are here on behalf of our entire team. We have an interdisciplinary team from multiple different specialties. And that's what we'll be presenting on today. So Virginia IMPACT is an initiative that we've built around 3 core principles. We've been working to engage an online community of practice through web-based learning and discussions, as well as focusing on technology and telehealth tools to help optimize telehealth use in congregate care settings through Virginia. So we started this initiative. It was initially funded through the Virginia Department of Health in response to COVID. And we brought together this community of practice to really kind of assess the needs across Virginia of clinicians and administrators in long-term care facilities. And so we surveyed our community of practice, and we were able to get a pretty good representation across our Commonwealth to assess telehealth use patterns, both before COVID and then after COVID as well. And what we saw from that is not very many people were using telehealth in long-term care facilities, at least in Virginia, before COVID. During the public health emergency, skyrocketed. We needed some way to take care of our patients. And then following the public health emergency, we still found a space for it. More people were using it than before and really trying to figure out how to best use the tool. So we also, in the survey, wanted to know about benefits and barriers that people had either anticipated or were surprised by and experienced with telehealth implementation in their facility. 3 of the barriers that were highlighted in that survey were connectivity, lack of operational workflow, and that the technology was just too complex. So when we were focusing our IMPACT initiative to build kind of beyond the public health emergency and looking forward, we wanted to focus on some of those barriers. Connectivity, as we all know, is a very complex multi-system issue that an individual facility can't change, something we all need to work together with, but an individual facility can't really change their connectivity. But creating an operational workflow is something that an individual facility could do to help implement or to help optimize telemedicine at their facility. And that's one thing that we wanted to help facilities do. In addition, technology being too complex. So our patients often find it too challenging to log on to their patient portal and click a link and go back to the email and click back into their chart. And there's just a lot of different barriers sometimes just in the technology alone. And so what we wanted to see if we could try to create a patient-facing interface that really simplify the technology to make it something that could be usable by the majority of our patients. So based on the survey, as well as obviously reviewed the literature and on-site facility visits. We had different focus groups, and really we're highlighting the same barriers over and over again. And that's where we really decided to focus on operational workflow and the technology. And so we engaged with interested collaborating partners, interested congregate care communities throughout Virginia, who were looking to optimize their telehealth program. And we first met with their leadership to engage them virtually and really help to identify what are their goals for their telehealth program. We met with the leadership to kind of help to focus those goals. And then our team would do an on-site assessment to produce kind of an executive summary and a consultation report about how they could perhaps start to implement telehealth in small, manageable steps. And then our team would be available for ongoing troubleshooting, problem solving, just helping them in their implementation. And Anthony will talk a little bit more in a specific detail and case example of one of the communities that we're working with, but just in kind of as a framework and background of how we would approach these telehealth consultations, we created the framework, which we refer to as the 4 I's. And so the first step is to initiate helping to identify based on the facility's goal, what types of activities could they initiate with the infrastructure that they already have? What could they put forth? What could they start to bring together? What team could they build? Then how could they integrate that into their daily practice, incentivize members of their community to use that, and then share what they learned and inspire others. And so this is a 4I framework that we created to help facilities in terms of identifying their goals and then optimizing the process. And then from there, that can really grow to lots of different opportunities. So with that, to talk about a specific program that we've been working with, I will turn it over to Anthony.
Great, thank you. So what I'll do, I'm going to talk about kind of our guiding principles when we're at the facility level, and I'll revisit the 4I framework that we talked about, and then kind of put that in the context of working with our partners. And so we collaborate currently in Southwest Virginia with an area agency on aging and a PACE program. And so we'll go through just generically the core principles right here, and then move on and put things into context. This is kind of what we really kind of keep in mind when working with folks in long-term care settings, congregate care communities. And we really, try to take with us the awareness of where folks in these settings are coming from. So program implementation on a good day is hard, or in a good year is hard. So we really try to think about the challenges that long-term care staff face. And we try to make sure things are in small, achievable steps and a tiered approach so that things can move along in a smooth fashion. We keep data in mind. And we talk about our interventions and telehealth implementation being data-driven on the front end with respect to really identifying a scope of the telehealth project or telehealth implementation, initial patient selection, and initial use case. So that's really front-end data-driven. And then we also work with facilities to consider what metrics will we follow to determine if what we're doing is effective or not. So looking at baseline metrics that are relevant to that level of care, and then following them at specified intervals, following those metrics after telehealth launch. And then I'm actually going to comment a little bit differently than the aim for routine use, but I'm going to come back to that. So keep that in mind, because I'll comment on that later. But I'm in a transition phase here, and I've changed around a principle or two. And so the third principle that I like to consider and keep at top of mind is barrier mitigation. And we talked about identifying anticipated and experienced barriers from the standpoint of clinicians and administrators in long-term care settings. And we found that it would make sense for us, one, to work on barriers that we could positively affect or mitigate, and leave the other ones to the folks who can. So we don't have a direct impact on connectivity, but we felt like we could address the facility and clinician side through workflow improvement. And then we also feel like we can address the patient or participant side of the telehealth encounter through making the technology a little bit less complicated and a little bit more accessible for participants. So with respect to with whom we collaborate, currently we're very active in Southwest Virginia. We work with we work with UVA-Wise and the Healthy Appalachia Institute to help kind of guide our assessments and really get a good handle of the challenges that face Southwest Virginia. And we also are working currently, like I mentioned, with an area agency for aging in that region. And under that AAA is a PACE center. And just to do like a 30-second fill-in with respect to the PACE level of care, PACE is a generic abbreviation for Program of All-Inclusive Care for the Elderly. It's a managed care organization for frail, medically complex elders. Typically, they are living in the community at the time of enrollment in a PACE program. It's a capitated payment system, so Medicare and Medicaid traditionally pay the PACE program a capitated payment per month per participant, and the PACE program has to take care of all the needs, all the medical needs of those participants each month over the course of their lifespan, really. With respect to the PACE program, I'll get to the initial use case that we're looking at, and then we'll go to the next slide. So typically, a PACE program is run out of a PACE center, which is a brick and mortar building open Monday through Friday, business hours. And an interdisciplinary team works out of there and takes care of the participants across, in this case, across a 3-county service area. So, and it's quite a large geographic area. So given that the PACE Center is closed other than business hours, that leaves times of routine low staffing after hours and through the weekend. And so during those times, typically a single on-call nurse fields calls from their participants and makes an assessment on the phone with respect to what to do at that juncture. So those decisions on the part of the on-call nurse could be anything from a basic conversation to scheduling a primary care visit the next day in the PACE Center to a nursing visit that day when they receive that phone call from the participant, to escalated care with respect to emergency department or hospital kind of thing. The initial use case typically, or what we're working on right now. So, and the use case for telehealth in this situation, which we would consider a telenursing encounter. The on-call nurse receives the traditional phone call that they normally would from the participant, runs through a couple questions to rule out, a significant emergency that would require EMS dispatch immediately. Do you have chest pain, shortness of breath? Are you injured or in danger? If the answer to those questions is no, then the nurse can talk the participant through, okay, can you safely access the tablet in your home? And the participant walks over to the tablet, or wheelchairs, mobilizes over to the tablet. And what we have designed to be set up would be the nurse has a pre-configured teleconferencing room open on their iPad. The participant gets to their tablet in their home, touches the screen to turn on the tablet, touches the single icon that is available on the tablet, and then they enter the waiting room, and then they touch one more button, the join button, and then enter the conference call with the on-call nurse, at which time the on-call nurse says, it confirms that you can see and hear each other, and then they hang up the phone and proceed with the assessment that the nurse previously would have done over the phone. Now, the overall objective in this context would be that the nurse could get a better overall assessment, say situational assessment of the participant through visualization, through seeing what the participant looks like, seeing the background, and that kind of thing. And really our working hypothesis would be that the nurse and the participant may be more satisfied with that process. the nurse having achieved a better assessment in general, could make a better decision, maybe triage a little bit more effectively, prioritize their day a little bit more effectively, given the service area that the one nurse would need to cover during these on-call times. And then ultimately, and we don't know this yet, but perhaps make a decision that would avoid an unnecessary emergency department visit or an unnecessary hospital admission, and really reduce the risk associated with the trips through the system that happen. And to avoid something that's unnecessary would be the ultimate outcome. So we, as we move forward, we'll follow those metrics with the PACE Center that we partner with at this point. So to put kind of our guiding principles in context a little bit more with the PACE Center, the 4I framework is there on the left side of the screen. We start foundationally at initiate with things like identifying a telehealth champion and team, and satisfying regulatory requirements from the standpoint of HIPAA and consent, moving through kind of, again, small steps, achievable. The PACE could work at their own pace if they choose, and kind of take a deep breath in between each tier, but moving through integrate, where kind of the full scope of the initial telehealth initiative is defined, technology is set up, progressing through incentivize, where the overall goal would be to launch the program in this phase, but considering metrics, make sure you identify metrics that you would use for program assessment, training on mock encounters, and getting really buy-in from both sides of the encounter. And then finally, inspire, which is really making sure that the program is sustainable, replicable. I'll refer back to that shoot for routine use, and I think that's applicable here in this situation. So we talk about that as in the organization is able to achieve kind of a simmering competence across staff and comfort with the use of telehealth and across participants and caregivers, so that ultimately in this final phase, we like to, our initiative was actually born out of the COVID-19 pandemic, and thinking back to how telehealth was ramped up real fast at that point in time, it wasn't real smooth in many places. And so part of our kind of shoot for routine use objective is that if or when there is another emergency or pandemic that limits the movement of staff and participants in this case, the organization can pivot to total or near total use of telehealth in case of that kind of a situation. And we also we want to share what we learn, and we want to work with places to help share the lessons learned systemically. And then on the participant side, so that's workflow. We address workflow through kind of program implementation workflow, but in there, like in the incentivize and the integrate phase, when we talk about mock encounters, we also want to work through day-to-day workflow with staff and clinicians, and so kind of on both levels with respect to workflow. Back to the participant side of the encounter, the technology too complex barrier we feel is important, and we address that through that kind of that whittling down of the tablet on the participant side of the encounter to what we call kiosk mode, and pre-establishing the teleconferencing room so that the actual onboarding onto the telehealth encounter or telenursing encounter is facilitated. And as Dr. Archbald-Pannone mentioned, doesn't require logins and usernames and passwords or that kind of thing, which is often quite difficult on the participant side. So moving forward, we are on the verge of launching this particular project with the PACE program. We plan to collect qualitative and quantitative data to kind of assess how this intervention works, specifically the simplified telehealth interface on the participant side. And so we're within, I'd say within the next 3-4 weeks, we'll launch this program with them. And then we're also working with that wider area agency on aging with respect to establishing some telehealth access points, both fixed and mobile. And they would really like to focus on 2 state mandated responsibilities, which is one-on-one nutritional counseling and group nutritional education. And so that's kind of where we are with respect to our engagement and work with the folks in Southwest Virginia. And that's it for me. I think we can open things up and take questions and panel discussion.
Thanks for that great presentation. I saw in one of your slides that you had that you were providing care across rural communities in Appalachia, and that's something I'm very passionate about as well. So I don't see any questions in there. I'll remind the audience, if you have any questions, please put those in the chat and we'll be able to ask the panelists. Moving into our panel portion, Kristin, do you want to introduce yourself? And after that, I'll ask Kristin.
Sure. Hi, I'm Kristin Ritchie. I'm a geriatrician and palliative care physician here up in Boston at Mass General Hospital and Harvard Medical School.
Wonderful. Thank you. Kristin?
Hi, everyone. I'm Kristin Rising. I'm an emergency medicine physician and researcher at Thomas Jefferson University in Philadelphia.
Thank you. We have a great panel today. So we'll just jump right into it. The first question is, what other types of organizations could this framework work for? And Anthony, I'll ask you first.
So considering PACE's level of care or model of care, it's a value-based organization. This particular use case is not focused on being embedded in an EMR, and it's really not focused on billing at this point in time. It's more or less a telenursing encounter to improve care management, prioritization, and ultimately and potentially saving money and getting the right care at the right time to the participant. So the example that I used earlier, if the need of the participant is such that the participant was thinking, well, under other circumstances prior to the telenursing encounter, I'll just call EMS and go over to the hospital and get them to check out this stomach pain. Ideally, if the nurse could get a better assessment, talk through things, make a bit of a better connection with the participant, perhaps the nurse could offer alternatives like, well, I'm going to be in your region in another hour. I could come to a nursing visit. A lot of times you wait a long period of time on the gurney at the hospital. If you want to wait, I'll come to a nursing visit. Or perhaps, how about I set you up to see the doctor in the PACE clinic tomorrow and talk through those other options with a better connection via the telenursing encounter. So that was I would say other organizations would be other value-based organizations. We have worked with a school for people with neurodevelopmental disabilities, which we've not implemented anything with them, but it would be a similar kind of a circumstance where it would be more of a care management telenursing encounter. We've also had a conversation with a hospice organization to similar effect with respect to what things would look like from that standpoint. Not a billable episode, but more or less, care management telehealth episode.
Any other panelists want to chime in on other types of organizations?
I'll just weigh in one comment that Anthony made, and I think having systems like this available as that option for, you don't call EMS, you can call in and work with someone. Like, certainly there's a lot of value to. We, do that within our own organization at Jefferson, where Jefferson insured folks can call our telehealth line internally and help get triaging for kind of what amount of care do they need or not need. And in fact, if ultimately needing to go to the emergency department or the urgent care within our system, those copays get waived, which really does incentivize people calling to get that help with that initial kind of like, what do I need? We've had many instances, right? People are like, I'm outside the urgent care. And I'm like, great, like you don't need the urgent care today though. So you can go there totally. I'm just like, we won't be waving you inside the system, but setting up those models, I think, is really helpful for people. And I have seen many folks who we can de-escalate care. And I've seen many folks also who don't think it's an emergency, who I'm like, actually get to the emergency department right away. And so having that set up is really helpful for people, I think.
And just to add to what Kristin said, I think that any person for whom a trip to a bricks and mortar facility is difficult, and Anthony spoke to the PACE program where that's often the case, those are the folks we should be serving by making sure that they don't have to, unless they really, really need to, as Kristin noted, like, you know, sometimes people don't know that they need to go to the ED, but unless they really need to, wouldn't it be awesome if we could make sure that they were able to get those services in the home and have somebody set eyes on them in the home so that they can avert a potentially incredibly taxing or exhausting trip to some bricks and mortar facility.
All good points. So how do you determine the best telehealth goals to tackle? Laurie, what do you think about that one?
Yeah, I think, you know, for our program, we, you know, try to come in with what I refer to as a listen first approach, in that when groups or communities want to collaborate with us, to really listen to what their needs are. Some of the organizations that we partnered with have come to us with a very specific goal in mind for their telehealth programs, and others have gotten there through collaboration and discussion. And so I think what's important for our team to remember is we don't have the answers to what's the best goal for the organization, but to help them work towards identifying goals for their own organization that are, you know, attainable, you know, and measurable, and we can see success and build from there. So trying to work with organizations to really focus in on an attainable goal that we can implement, I think, is the most important piece.
Any other panelists have thoughts on the goals to tackle?
I guess I'll weigh in a little more on that one too. I think kind of the work we do within my center and all our research portfolios, you know, focus on really saying, well, if we want to figure out what we need to help with most, we got to help the end users first. And so I think, be it patient populations or if it's staff in facilities that we're trying to decompress parts of what they're doing, I think being thoughtful about, in our first steps of planning, engaging with the populations of interest and figuring out what are the goals, like what ends are we trying to get to, what are the biggest problems we're trying to solve, how can we be helpful here, I think is always the most important starting point for really identifying what those are. So, you know, I think that applies across in any of this work as well.
And maybe this goes without saying, but, you know, with our recent hurricanes, we see the importance of access, and that if your road is cut off and you can't get from here to there, that's a real problem. And a lot of people cannot access telehealth because they don't have connectivity. And so the connectivity piece, I think, is a huge equity piece. It's a huge opportunity for us to get creative and solutions oriented with our both government and community partners, our business partners, and say, what does it mean for every person who needs it to have access from a connectivity perspective to this kind of support?
Good example with the recent hurricanes. Okay, what measures do you recommend using for program assessment when implementing telehealth services for older adults and complex care needs? Kristin, can you answer that one?
Happy to start. So there are a lot of things that I think are important for us to be considering. And the big one, probably for starters, is around screening for capacity, the capability of being able to benefit and use these kind of services. And this may be something as simple and straightforward as considering sensory impairment. You know, visual impairment is very common among older adults. About 1 in 5 older adults has meaningful visual impairment. Hearing impairment, a very large proportion of older adults have hearing impairment, and among those who are 85 plus, Up to 31% have severe or profound hearing impairment that can truly influence the ability to have the kind of sort of interactions that we now come to routinely expect through telehealth. Thinking about, we've already talked about connectivity, but also around functional limitations. We did a study a few years back with homebound older adults where we were asking them questions about what they thought were important research questions to answer related to care of those who are homebound. And one of the more poignant situations was a woman who, and we sent them all tablets that were sort of had easy buttons for Zoom calls. And so all they had to do was literally just press a button and they were able to be on one of our Zoom calls. And the issue here was not that she couldn't press the button, but that because she was bedbound, she could not reach the tablet. And so functional limitations can be a very meaningful issue for someone depending on how profound they are and how much they affect mobility. And then I think thinking about technical capacity, which is not just an age-related issue, it's an issue across the age spectrum, I would say. And then also, if they have care partners, what is their level of stress and their ability to actually navigate and support a telehealth encounter? So those are things that immediately come to mind when I think about sort of what do we need to be considering for provision of telehealth services in this population. And I'm sure my colleagues have other good ideas.
Sure.
And working with the, just if I could comment a little bit more on that, and working with the PACE program, we work with administrators, the clinicians, and then their IT staff as well. And they actually came forth with this concept and use case, and they also considered the participant selection and discussed those exact points, caregiver support, kind of functional and sensory impairment, cognitive ability, digital experience and literacy, connectivity. And so they actually kind of hashed out the original readiness assessment across really the initial number of participants who will interact on telenursing encounters is 3. So again, kind of back to those small steps, but I think it was crucial for us and very informative for us to have such a collaborative staff that kind of thought through this and who this might work with.
I'm going to add in a little bit more also to Kristin's comments, which I completely agree with, and say that kind of plug a recent screener that my team developed called the Digital Health Readiness Screener. And like in here, just thinking, right, when you're thinking about measures and for any group, it's like thinking about, is the group we're looking to serve, like, do they have what they need to be ready, right? And I think an important part about telehealth is ultimately, if we're measuring use alone, right, a lot of people look to use, like that's inadequate because different people are ultimately going to have different needs for use and ultimately decide that they want to use telehealth more or less. And I think that's totally appropriate, right? Telehealth is a part of care. It's part of a hybrid model. We're not looking for everybody uses telehealth or not. And for some people, it's going to be relevant to use it 5% of the time, and for other people, it's going to be 95% of the time. What we want to make sure is that everyone is sufficiently ready to use telehealth if and when they decide they want to. And so my team spent a lot of work over the past kind of year plus in developing a screener so that we could somehow concretely think about what are all those aspects that are needed for readiness, which came up with kind of 2 overall, factors within it to think about. And one of them was technical readiness, which we've talked about a lot here. And the other one, the other domain that emerged was quality of care readiness. And that thinking some about people's even trust in the quality of telehealth, trust in using devices to receive healthcare. But many of the specific items, this screener was just very recently published in JAMA Network Open. So you can look for this and see all the items within. But some of those items are getting at exactly what you're saying, Kristin, right? So there's one item. Do you have any physical challenges that limit your use of telehealth, right? And so thinking about like, what are those aspects, right? Do you have a place where you're actually comfortable and it's private enough to talk about your health needs, right? Like a lot of those nuanced things, much more than just, do you have a device that you can use? But I think thinking in this frame and thinking about, are we assessing that we've addressed all of the kind of areas of readiness that populations may have, to think about kind of adequacy of the supports we're providing in the program is a kind of useful way to go about really assessing adequacy.
You read my mind. My next question was about the assessing telehealth readiness. So do any of the other panelists have anything to add on telehealth readiness?
Well, I would just add that the tool that your team has just put out, I think, is a really important piece of what we're working with here, right? Being able to, as you mentioned, kind of assess those needs. I think when we're talking about the congregate care setting, then thinking also about, is the facility ready for telehealth? What staffing look like? What staffing capabilities? What's connectedness on that facility-based level? I think is an important kind of place to move going forward as well.
Great. So we do have some questions coming in from the audience. And again, I remind the audience that you can put your questions in the chat. We've got a few of them in there. So one question is, disparities in digital access can exacerbate already existing health inequities. How do you think provider organizations using telehealth platforms can bridge these gaps, particularly for older adults in underserved areas?
Well, we've sort of touched on a few of them, and I'm sure others can add. I think there are ways to offer hotspots to folks. There are ways to offer internet subscriptions. There are ways to bring in tablets that have internet subscriptions already attached to them. So there are a lot of things I think we can do on our end to reduce some of those connectivity and sort of at least internet access disparities, which are profound. And I will say, in a study that we did during COVID, there are a number of homebound older adults in this country, and the number went up substantively. No surprise, during COVID, the number of folks who were homebound, especially from Latino and African American communities who did not have Wi-Fi access, was also pretty large. And it did make me feel like we needed to be much more proactive about addressing those issues of connectivity, as opposed to just saying, go to your public library or something like that, which is often what people will say.
And specific to the PACE program we're working with and the wider area agency on aging, they actually just received, well, not just, but within the past year, received grant funding to establish Starlink broadband connectivity across, I believe, 150 of their members and participants. So I do think that, so things are coming together. I think efforts are converging at this point to more effectively address those disparities. And in this, I think rurality is a barrier magnifier. And I think when you consider kind of rugged geography and hard to reach places, it's magnified, really, the lack of connectivity. So efforts like that, at least specific to the PACE program and the AAA we're working with, are addressing that connectivity, those disparities.
Another question that came through is it true that older adult patients prefer waiting for in-person visits over telehealth due to concerns about care quality? What strategies do you recommend for alleviating this concern and others and fostering trust in telehealth among this population?
I'd say probably depending on the person, it's true or it's not true, right? I think it's not actually an issue that's specific necessarily to older adults. It is an issue that is experienced across populations, though. So, like, again, much to the point, like being aware that all these kind of problems exist was behind, for me, and think about our system behind developing the screener, now looking to say, can we implement it places? Because I think there are very different interventions for people who we need to get them Wi-Fi, or we need to kind of get them some literacy training. And those that maybe it's, sometimes it may be talking with the provider. I think relevance is a kind of part of it for some people, not understanding, right? I've gotten healthcare in person my whole life. Like, why would I switch now? Why are you trying to push this on me? And I think some of that for providers explain, again, like getting to the, it's about hybrid care. You're not giving up in person, right? You're not seeing me anymore, but there are sometimes I can get you results sooner. We can touch base about problems we're having. We can limit, your caregiver needing to take off work and bring you in. And so helping them some understand, I think, the relevance across some of this. and also help with addressing some of those kind of barriers around trust through, conversations with kind of trusted people within the community. I think the trust component is hard. And I do think that what we see in telehealth is probably amplified because some people don't trust technology as much, but I think it also lower trust in telehealth is probably reflective of people who already are having lower trust in the healthcare system, right? It's not a unique issue to telehealth. It is something that we are also seeing in telehealth. And we haven't figured out the formula, right? We still do have challenges with certain populations across the system, but I think having conversations and patient conversations to understand kind of where those barriers are and helping to at least give them the understanding of how we think that this can be amplifying their care and not replacing, aspects of care that they're receiving elsewhere.
Any consideration of expanding into telemedicine for specialized care?
So I think in this initial kind of step into telenursing for the PACE Center, I don't see it happening in the near term there. As we work with the AAA, which oversees the PACE program, and we're actually fixing to get an actual fixed telehealth access point, as well as 2 mobile platforms with respect to mobile telehealth platforms. And we've talked with them about deploying one of those mobile telehealth platforms to the brick and mortar PACE Center, so that, within that PACE Center, they get their primary care and ancillary care. Their specialty care specific to Southwest Virginia is often in Tennessee or Kentucky or Charlottesville at UVA. So transport is lengthy and challenging in that context. So we have talked to them about a mobile telehealth platform being deployed to the PACE program, and then pursuing specialty care follow-up visits through that. But in this initial use case, it's really just designed for at this juncture for the telenursing on-call management kind of issues.
And then I've got one last audience question. To what extent does the program attempt to include relatives, so thinking adult children, for example, in the care of the patients? Is that a focus? What technology are you employing to enable the relatives to participate or assist? And what problems have you encountered with the tech or otherwise? How have you handled them? Thanks.
So at this point, we're relying on guidance from the PACE program, and part of that, kind of their initial readiness assessment of the participants who will be involved in this first iteration of telenursing, was caregiver support. And so as they go in, kind of the background to launching this trial, the tech folks and the clinical folks at the PACE program will have gone into the participants' homes, set up the tablet in a safe location that the participant can functionally access, involve caregivers at that point in time for training, and conduct mock encounters between the participant and the family and the clinicians. So that work has been done kind of by them, but certainly caregivers are involved. And at this point, the involvement is local in-home caregivers, not caregivers that aren't home. That's certainly something that we could expand to with respect to if a caregiver doesn't live in the participant's home, involving them down the road in the telenursing conference, if you will, or encounter. But at this point, the program itself is guiding us through caregiver involvement.
I've got another question. So Dr. Ritchie, I'm just wondering if there are lessons learned from home-based primary care learning network that we can share. And to the rest of the team, is there anything else that you would like to include that you think would be helpful that we didn't cover?
Thanks for that great question. We actually have gotten very interested in our home-based primary care learning network, which is a consortium of learning networks a consortium of home-based primary care programs from around the country about how they're using telehealth. And I think, probably before the pandemic, those numbers were pretty small. Went up a great deal during the pandemic, and now about 90% of those in our consortium, continue to engage in the use of telehealth. probably most commonly for urgent care services, but also some follow-up, some patient monitoring, and you know, discussion of results, et cetera. So what I would say with that is that there is a huge amount of adaptability that we're seeing in healthcare and including in home-based primary care, that for the reasons we discussed earlier, because of people's functional limitations, there is a way you can stretch your resources sometimes by, it's kind of what Kristin was alluding to earlier, by looking and seeing what's going on. Does this require an urgent home visit or not? What can we assess visually, and then what needs to be assessed more comprehensively? So I think there's a lot actually that we're learning from home-based primary care. The other thing that I would say home-based primary care and home-based medical care practices are doing that we can all learn from is really thinking about what array, what spectrum of technology can we be bringing into the home? You know, what kinds of remote patient monitoring services are helpful? What are other kinds of equipment that can be servicing people so that we don't have to rely so heavily on bricks and mortars care? Could we be bringing into the home? And there's just a lot of creative work happening in that space. And what's delightful to see now is, you know, our emergency medicine colleagues, our telehealth colleagues, our PACE colleagues, all coming together and saying, okay, this is the shared place where we all can grow and we can provide better care. And then a point that's brought up in the CE4TA guidelines is how can we also coordinate these services? How can we integrate these services so they're not a bunch of one-offs, and where we can actually think about, if I'm in the home or if I'm caring for someone in the home, I'm able to communicate with my colleague in the ED or in the PACE program in a way that actually is both real time and really effective and person-centered for that patient.
Specific to our example with the PACE Center, nurses' aides at PACE are called Universal Care Partners, or UCPs, but they're often in the home. They spend a lot of time in participants' homes, but we've considered kind of down the road as the program becomes more comfortable with telenursing and with kind of conducting this initial round of encounters, is the potential of training the Universal Care Partners in digital navigation and making some type of a protocol where you're developing some type of protocol where the Universal Care Partner, perhaps the participant needs a follow-up primary care visit and is homebound. The Universal Care Partner could go to the participant's homes. There could be peripheral, medical equipment there, to Bluetooth equipment to obtain vitals and weights and that kind of thing, and then help conduct that side of the encounter with the primary care physician or provider back at the PACE Center. So as we kind of move along and they become more competent and comfortable with the process, adding layers like that and utilizing staff that's already in the home is kind of what we're thinking of moving forward.
I love that, Anthony, and I think that also relates to some of the work that's happening in community paramedicine, where our community paramedicine colleagues are also serving as that bridge for guiding us around next steps for care.
Well, I'd like to thank today's presenters and panelists for insightful and engaging discussion. It's been an honor to be your moderator. Before we wrap up, I want to let you know that the session recording will be available on demand on the CE4TA site. Our next webinar will be in November, and we'll share more details of the coming days. So please stay tuned, and thank you for joining us today.